I'm Dr. Priyanka Wali, and it is a real pleasure to be speaking on today's topic, which is something that's very dear and near to my heart and my womb. Full disclosure, I am a paid physician at Virta Health. I do see patients for them, and I am also a paid consultant for some startups in the Bay Area. Why am I giving this lecture, though? I believe that there is an important connection between insulin resistance and sexual health, and I'd like to educate you about this. Simply put, you have to watch what you eat if you want to perform in the sheets. So today we're going to go over some of the statistical data on the prevalence of sexual dysfunction in both men and women. We're also going to explore the correlation between metabolic syndrome and sexual dysfunction in both genders. And I'll spend a little bit of time exploring the connection between insulin resistance and fertility in both men and women. And I hope if there's anything anyone's going to get out of this talk, if there are any physicians in the audience, I hope that they start to look at sexual dysfunction as a reason to begin screening people for insulin resistance. Now, when I say sexual dysfunction, what am I talking about? Sexual dysfunction is defined as any disturbance in sexual desire or in the psychophysiologic changes associated in the sexual response cycle in both men and women. And the sexual response cycle is a series of 4 physiological phases that happen in both men and women during intercourse. So if you look at the chart here, the sexual response cycle, sex first starts with arousal. There's an excitement phase followed by plateau, and then it peaks at orgasm, and then there's resolution. And some people who are carb addicted actually say they experience this cycle when they eat carbohydrates as well. But that's a different talk. Now, I want to emphasize that I'm just going to talk about one aspect of sexual dysfunction. Sexual dysfunction is a multidimensional, multifactorial disorder. There's many possible causes. Many of the medications that we commonly prescribe, like antidepressants or beta blockers, can impair sexual function. Any stress to the body, like a recent illness or surgery, can also lead to sexual dysfunction. Psychological trauma plays a huge role in someone's ability to perform sexually. Hormonal changes as well, including naturally occurring changes like menopause or the use of exogenous hormones like oral contraceptives, these can all play a role in sexual dysfunction. Now, I'm not an OBGYN, I'm not a psychiatrist, I'm just an internist. So for today's lecture, I'll be focusing on the vascular aspects and how vascular dysfunction can lead to sexual problems. And one thing to say before I reveal the data, there are major issues when it comes to sexuality studies currently. Most of the studies done are done on heterosexual couples, white couples who come from middle to upper socioeconomic classes. And most of the high-quality trials focus on men and male sexual dysfunction. The studies on female sexual dysfunction are flagging far behind. And I don't know if that has to do with societal taboos regarding female sexuality or the fact that there's a lack of validated definition of what female sexual dysfunction is. But that being said, the point is a lot of this data needs to be treated with caution. There are very few rigorous RCTs. Most of the data is observational, so let's take it all with a grain of salt, okay? But I can tell you, based off of the prevalence studies, sexual dysfunction is highly prevalent in both sexes, and it's more common in women. In fact, worldwide, 40 to 50% of women have some issue with sexual dysfunction, and that's irrespective of age. For men, the numbers are lower, and age plays a greater role in whether a male will have sexual issues. The most common complaint for men was erectile dysfunction, so men are frustrated because they can't perform. The most common complaint for women is low sexual desire, so women are frustrated while they can technically perform, they just don't want to. And married couples had a lower risk for experiencing sexual symptoms compared to their non-married counterparts. And when I read this, I found this to be very interesting because it's unclear, is it that married couples are more likely to, because they're together, work on their sexual issues and therefore complain less? Or is it that married couples are just so unhappy that they've given up complaining and just don't want to talk about it anymore? So I don't know, it's something worth exploring before you file the divorce papers. But anyways, let's get into where most of the data and research has been done. Male erectile dysfunction. Can't get it up, can't keep it up. And as you saw with the commercial that I played, the pharmaceutical male sexual enhancement industry is a multi-million-dollar industry, folks. Men believe that if they take a medication, they can improve their odds of having an erection. But I'm here to tell you that, yeah, the odds are good, but the goods are still odd, because erectile dysfunction is a measure of early cardiovascular disease. So this was data gathered from a National Health and Nutritional Examination survey. They surveyed over 20,000 men, and they asked them, do you never have an erection, or do you sometimes get an erection? And about 4,000 men replied yes, they did have erectile dysfunction. So they then did a logistic regression analysis to look at how many of those men had either undiagnosed diabetes, undiagnosed high blood pressure, or undiagnosed hypercholesteremia. And what they found was that there was a higher percentage of men with erectile dysfunction who had undiagnosed high blood pressure compared to men without erectile dysfunction, but after adjusting for confounders, that data wasn't statistically significant. For cholesterol, they found no statistical correlation between erectile dysfunction and having high cholesterol. But with diabetes, however, erectile dysfunction was strongly associated in undiagnosed diabetes in both the adjusted and unadjusted analyses. In fact, that relationship was strongest for men in the age group of 40 to 59. In fact, they found that the predicted probability of having undiagnosed diabetes in someone without erectile dysfunction went from 1 in 50 to 1 in 10 if they did have erectile dysfunction. So, why does this happen? It starts with obesity, specifically visceral obesity. Visceral obesity actually does a double whammy to the penis because it leads to both hormonal and inflammatory changes. So hormonally, adipose tissue contains aromatase, and aromatase converts testosterone to estradiol. So being obese, you will be in a high estrogen state and a low testosterone state thanks to aromatase. On top of that, obesity is also a pro-inflammatory state, and it results in the release of pro-inflammatory factors, which then lead to direct vascular damage to penile tissue. So a combination of that vascular endothelial damage accompanied with the hormonal testosterone deficiency, you're not going to have a functioning penis. So this study was very dramatic. They took 803 white men who presented for the first time to an Italian clinic with sexual dysfunction. And these men could have complained of anything. They could have said they had erectile dysfunction or premature ejaculation or decreased libido, blue balls, you name it, it doesn't matter. And what they found was that about 30% of these men were diagnosed with metabolic syndrome, and practically almost all of them had erectile dysfunction. What's fascinating about this study is that they then went on to do blood glucose parameters, hormonal levels, but they also went ahead and did penile Doppler ultrasounds at baseline and 20 minutes after injecting prostaglandin into their penises to induce an erection. So they measured baseline blood flow velocity and peak blood flow velocity. And this, my friends, was where the soft science gets hard. So they found that there was a progressive decline in penile blood flow, both at baseline and at peak velocity, as the number of metabolic syndrome components increased. And this trend was significant even after adjusting for age. So essentially, those with metabolic syndrome had worse erectile dysfunction, essentially due to impairment in penile blood flow. Metabolic syndrome is also associated with hypogonadism, and they found that those that had 3 out of the 5 components of metabolic syndrome had a 3-fold increase in the prevalence of hypogonadism. If they had 5 out of the 5 metabolic syndrome components, that prevalence went up to 10 times higher to have hypogonadism compared to those that didn't have any metabolic abnormalities. And out of the components of metabolic syndrome, the major determinants that were associated with hypogonadism were increased waist circumference and high glucose. So again, insulin. They also found that circulating total testosterone levels decreased, again, as the number of metabolic syndrome components increased. And this goes back to the same component, that adipose tissue releases aromatase, so testosterone gets converted to estrogen. So right now, Cialis, Viagra, this is all getting prescribed, but you must consider screening men who complain with erectile dysfunction for diabetes and other secondary medical causes before prescribing vasodilatory medications. And so the question is, does this similar phenomenon happen in women? And like I said, the studies are not as rigorous as in women. But I was able to find one interesting study, again, also an Italian sexual dysfunction clinic, so I'm not sure what's going on in Italy, but they really seem to have it together in that front. This was a study that looked at clitoral vascular resistance by measuring an index called the clitoral pulsatility index, which is essentially reflects a resistance to blood flow. In this study, they took 71 straight women who came to a clinic complaining of sexual dysfunction. Most commonly, they complained of low sexual desire. They also ran similar blood tests, looked at metabolic syndrome components, and they also did ultrasounds on their clitoral structures to measure the pulsatility index. And again, a higher pulsatility index, more resistance to blood flow. What they found was women with obesity or metabolic syndrome had significantly higher clitoral pulsatility indexes, even after adjusting for confounders. And there was a stepwise increase in the pulsatility index as the number of metabolic syndrome components increased. And this was, again, even after adjusting for factors like age, smoking, and years since menopause. What was also interesting about this study is that they looked at the association between the increased pulsatility index and other factors like the degree of body uneasiness. And what they found was that an increased pulsatility index was also associated with a higher degree of body uneasiness amongst women, especially in areas that were closely related to sexuality, like their womb or genitals or their breasts. So essentially, clitoral vascular resistance is strongly associated with metabolic syndrome, particularly insulin resistance, and this also leads to certain body image concerns. What I found that was interesting in this study, it was observational, it wasn't statistically significant, but they also observed that women who had diabetes had a higher content of collagen in their clitoral cavernous tissues. So essentially, this was evidence of smooth muscle degeneration at the level of the clitoris, which is really quite terrifying. So just like in men, women should also be screened for endocrine disorders if they're presenting with sexual dysfunction, and insulin resistance should be one of those disorders. For women in particular, you also want to make sure you rule out things like prolactinoma or thyroid disease, and make sure you do a pelvic exam to rule out structural issues as well. Now, before I move on to infertility, when I came to this conference, I noticed that there was a lot of attention recently in the media about this phenomenon called Keto Crotch. So I just wanted to take a slide to just give my 2 cents on that. So Keto Crotch is essentially some anecdotal stories of people who are endorsing that after switching to a ketogenic diet, they noticed changes in their vaginal odor. Now, any change in diet is going to change vaginal pH. I looked at the data. No one has done the study where they're going to do sniff tests while people are keto adapting. So I wasn't able to find any studies on this. But, if you think about it, In diabetes, recurrent yeast infections, vulvovaginitis, these are much more common in diabetes, which is a complication of insulin resistance. Sometimes the presenting symptom of diabetes can be vulvovaginitis. So I don't really know what to say. All I can say is that I would rather prefer keto crotch to candida crotch or any other type of crotch. And I can tell you that the internet certainly has a lot to say about the keto crotch phenomenon as well. So I'll leave it at that. See, I mean, some of these are real good. So now that we've talked about sex, let's talk about what happens after you have sex. You make the baby, or sometimes you don't. In 2010, they found that over 40 million couples worldwide were infertile. Men were about 50% of the reason that this was happening. And so when you think about insulin resistance, it's actually important to know that glucose metabolism is actually very important in sperm formation, as well as sperm motility and the ability of sperm to mature. In fact, if you look at the anatomy of a mature human sperm, there are glucose transporters all throughout that allows glucose to transport into the lipid bilayer. Sperm have a mitochondrial sheath, and this is where many oxidative processes take place. There's also the principal piece of the tail of the sperm, and this is where probably the most important glycolytic enzymes occur. And they found in diabetic mice in the rat studies who had defective GLUT9 transporters, essentially these rats also suffered from low sperm motility and had decreased fertilization rates. And when they corrected for the hyperglycemia, the sperm motility rates improved, and so did the quality of the sperm. On the human side, I was able to find one prospective case control study that looked at 160 men who had unexplained infertility, meaning that their sperm count was low, but their hormonal profile was normal. And then they compared them to 79 men who were definitely fertile, like they had fathered children. And they measured insulin resistance, they measured cholesterol, and they looked at their hormonal values. And what they found was that fasting insulin level and insulin resistance was significantly higher in the study group compared to the control group, which sets this idea that, insulin resistance could be a possible cause to explain infertility in men that have otherwise no possible etiology. Now, in women get a lot of attention when it comes to infertility, and the causes of female infertility are far and wide. You can have pituitary issues, you can have medical issues, or medication issues. From an insulin standpoint, polycystic ovarian syndrome is the most common cause of infertility in women. And as Dr. Fung pointed out in his talk earlier, polycystic ovarian syndrome is essentially insulin resistance at the level of the ovaries. You have chronically elevated insulin levels that then send signals to the ovaries to increase the production of androgens. The excess androgens lead to increased abdominal fat. The abdominal fat then worsens inflammation and insulin resistance, and it's just a vicious cycle that goes on and on and on. To reverse the PCOS, you must reverse the insulin resistance, and to reverse the insulin resistance, you must eat low carb. And these hormones then play a role with fertility. There's only 2 small studies that have been done that looked at a well-formulated ketogenic diet and its impact on women in PCOS and their ability to have children. The first study, it was a 24-week intervention. They took 11 women with PCOS and they put them on a true ketogenic diet, less than 20 grams carbs. Only 5 of these women were actually able to see through and complete the study, but they all had improvements in their hormonal profiles, including fasting insulin. And then 2 ended up going on and conceiving without the use of any fertility medications. Another study, again, a small study, they took 8 women with PCOS. They put them on a calorie-restricted ketogenic diet for 4 months. Half of these women were able to stick with the diet. And again, 2 of them conceived without any medical assistance. So granted, these are very small, non-randomized studies, But if you look at the numbers, 4 out of these 9 women in the 2 studies were able to eat keto for a substantial amount of time, and they conceived naturally. So they had about a 45% success rate. You look at the success rates of medically induced ovulation, it's about comparable, 30 to 40%. Plus, it's certainly more cost-effective to just switch a diet versus going through so many cycles of IVF. So before I conclude, I actually want to end with a brief history lesson, the history of Coca-Cola, because I think it's actually very interesting, and it is related to sexuality as well. So Coca-Cola was invented in 1886 by this pharmacist, John Pemberton. He originally intended Coca-Cola to be for medicinal uses, but he wasn't the most reliable guy. He ended up dying addicted to morphine and of stomach cancer, and it was really just a mess. So before he died, he sold Coca-Cola to a business tycoon, Asa Candler, in 1892. And originally, Asa wanted to sell Coca-Cola, but Coca-Cola as a business was not doing well. Then Mr. Candler figured out a way to make Coke sell. He realized that if you use beautiful young women in Victorian dresses and you get them to hold the Coke in a very promiscuous way, it will sell. And literally overnight, starting in the 1890s, Coca-Cola products shot in their sales. I mean, she's obviously a total slut for the time. And as the decades continued, Coca-Cola continued to use this type of marketing to cater to this idea that this is the type of sexuality that you can have if you drink this product. And they did quite well for themselves. You know, Coca-Cola now sells 1.9 billion drinks a day by selling us this idea. But I'm here to tell you that this is false advertising. And party's over, folks. 40% of Americans are obese, 50% are insulin resistant, and I can guarantee you they are not having a fun time in bed. So in conclusion, I think it's important to look at sexual dysfunction as a reason to screen people for insulin resistance. I think it's important that we're also mindful that metabolic syndrome as a disease, it does lead to significant sexual distress in both men and women. I think there should be more studies about unexplained fertility in men and screening for insulin resistance. And I certainly would love to see more studies involving women and sexual dysfunction. I'd also like to take a moment to just thank Jeff and Rod for letting me do this talk. This is my first time of giving a talk of this nature, so if you loved it, please tell your friends about it. And if you... and if you were offended or you hate it, just tell your family about it then. I also would like to thank a few friends of mine that helped me along the way, Dr. Saslow with reviewing the data, and then comedian Dan Gurin, who also helped me write from jokes. And then a big thank you to several ex-boyfriends who I met along the way, because without them, I would have not been able to sublimate my frustration into an educational talk. So thank you so much.